At 2 in the morning, a phone becomes a clinic. A tired parent shows a rash to a doctor on a video call. The doctor asks questions, gives advice, and sends a prescription to a nearby pharmacy. Nobody drives across town. Nobody sits in a waiting room. That is real care, and the speed matters. By March 2026, New Zealand's National Online General Practitioner Care Service had delivered more than 80,000 consultations. Most people using it said a timely appointment in person was not available, but fast access and continuity solve different problems. Fast access answers, "Who can help me now?" Continuity answers, "Who will notice what has changed?" That second question matters most when an illness lasts for years rather than days. Imagine a person who lives with diabetes, asthma, and high blood pressure. On Monday, she asks for another inhaler. 3 months later, she feels unusually tired. At the next visit, her ankles look slightly swollen. Each event may seem small to a clinician meeting her for the first time. Her usual practice sees a pattern. The nurse remembers that the tiredness began after a medicine changed. The doctor can compare the new blood pressure with earlier readings. The team knows which tests were ordered, which appointment was missed, and which plan was difficult to follow at home. The value does not sit inside one brilliant consultation. It grows between consultations. This is why a general practice is more than a shop that sells appointments. It is a home base for a person's health story. In January 2026, about 94% of New Zealand's population was enrolled with a primary health organisation through a general practice. Enrolment is voluntary, but it brings public subsidies and usually lowers the fee a patient pays. It also connects the person to a team that is responsible for an enrolled population. Since 2003, government funding for much of general practice has gradually moved towards capitation. Capitation means a practice receives regular funding linked to the people enrolled with it, not only a payment each time one of them enters the room. The formula has changed over time. From July 2026, it was designed to consider age, sex, long-term illness, rural location, and neighborhood deprivation. The principle is simple. A practice caring for people with greater needs should receive more support for that work. That design gives New Zealand a useful idea of primary care. The job is not only to repair the immediate problem, it is to prevent the next problem, manage several conditions together, and decide when a specialist or hospital is needed. Continuity has 3 layers. The first is information, test results, medicines, allergies, letters, and earlier decisions need to travel with the patient. A good record stops every visit from beginning with a blank page. The second is management. Somebody must know who will check the blood test, renew the medicine, make the referral, and call if the result is worrying. A plan without an owner can disappear between services. The third is relationship. Over time, a patient learns what can be said safely in the room. A clinician learns what is normal for that person. The quiet patient who usually says everything is fine may need a different question. The person who missed an appointment may have lost transport, money, confidence, or control of a busy household. A medical record can store facts. It cannot fully store trust. This does not mean every sore throat needs the same doctor. That would turn continuity into another barrier. Online care is well suited to many clear, urgent, and limited problems. It can help with a cough, a minor skin problem, a simple prescription, or advice when the local clinic is closed. For rural families, shift workers, disabled people, and parents with a sick child at night, distance can be part of the illness. Removing it can be a major improvement. New Zealand's service was built for that gap. It is available around the clock through registered health professionals. The public guidance still tells people to try their usual provider first when they can. It also lists problems that may need touch, movement, listening, a sample, or a close physical examination. The limit is not that a video doctor is less caring. The limit is the amount of the body and the story that can enter the call. New Zealand's Medical Council applies the same professional standards to telehealth as it does to care in person. A doctor must decide whether a remote consultation is suitable, gather enough reliable information, protect privacy, arrange follow-up, and explain when an examination in person is needed. Under the Medical Council standard, information about the care should be shared with the regular provider when the patient agrees. That transfer is the hinge between access and continuity. Without it, the video call becomes a separate island. With it, the call can become one useful part of a longer plan. The distinction is especially important for chronic conditions. Chronic does not mean dramatic every day. It means the condition continues and must be managed across ordinary days. Blood pressure may rise quietly. Kidney function may change between tests. A person may slowly use an inhaler more often. Several safe medicines may create a problem when combined. No single appointment contains the whole picture. New Zealand already has a program called Care Plus for some people with high health needs. It supports more intensive care through a general practice team. Eligibility can include having at least 2 serious chronic conditions, repeated hospital admissions, or frequent primary care visits. The expected work includes a full assessment, a personal care plan, and regular follow-up. Care Plus makes the hidden work visible. Long-term care is a sequence, not an event. There is still a hard tension. A person cannot benefit from a trusted clinician whom they cannot reach. In the first 3 months of 2026, only about 3/4 of general practices were accepting new patients freely or with restrictions. The country needs more access. Yet, an appointment target can also reward the number of doors opened without asking what happens after each door closes. If every urgent problem moves to the fastest available clinician, local teams may be left with the most complex work and too little time to do it. The answer is not a choice between screens and consulting rooms. It is a bridge between them. For a patient, that bridge can be practical. Use online care when the problem fits it, and waiting would make things worse. Have a medicine list ready. Say clearly which long-term conditions are being managed. Ask where the consultation record will go. If the advice changes a regular medicine or raises a new concern, arrange the next step with the usual practice. For the health system, the bridge needs shared records, clear clinical responsibility, enough local staff, and time for follow-up. Technology can carry information quickly. Only an organized service can make sure someone acts on it. Follow this channel if you want more calm stories about the systems behind everyday life in New Zealand. Return to the parent holding the phone at 2 a.m. For a sudden rash, the best doctor may be the one who is available. For an illness that changes slowly, the best care may come from someone who can see that this visit is not quite like the last one. Speed opens the door. Continuity remembers who walked through it.